Hello, everyone, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for September 26, 2018. Thank you for joining our presentation this month. Our presenter today is Shannon Mihalko. She is a behavior scientist in the Department of Health and Exercise Science at Wake Forest University with a joint appointment in the Department of Social Services and Health Policy at Wake Forest School of Medicine. She is involved in the clinical trials promoting physical activity and weight management in adults with chronic disease, including knee osteoarthritis and cancer. Her research examines determinants and consequences of behavior change and adherence with a specific focus on building self-efficacy in older adults to engage in physical activity and healthy nutritional practices on their road to independence. Welcome, Shannon.
Hi, thank you very much. Can you hear me all right?
Yes.
Okay, great. Well, first, thank you very much for inviting me to speak with you all today. And I'm going to be talking about intervention that we had, the IDEA study. And in this presentation, I'm going to focus mostly on the impact of the intervention on self-efficacy in our participants. So let's go ahead and get started. Again, if we could just focus on the bottom slide, it seems that that's how we're going to have to do this for today. So, okay. While decreased levels of physical activity, increased rates of obesity, and subsequent chronic disease in an aging population pose a risk to public health, the true concern lies in the combination of these factors. This domino effect is especially evident when talking about knee osteoarthritis. Knee OA is one of the most prevalent types of disability in older adults, and over 20 million U.S. citizens suffer from it every day. As the adult population continues to age, there is an increased prevalence of knee OA, and therefore a demand for effective interventions to alleviate pain and inflammation associated with this chronic disorder. As part of the treatment for knee OA, the American College of Rheumatology recommends weight loss and physical activity for obese adults who have this disease. Although exercise and weight loss programs have shown improvements in outcomes such as pain and mobility, the true problem lies in helping participants adhere to these types of interventions. The question is, how do we get older adults to exercise when exercise may be the very thing that causes them so much pain? As interventionists, and I work with our interventionists in our research studies, we talk a lot about what our role isn't. And our role isn't to make people motivated or to confront their resistance to exercise, or certainly it's not to be a personal therapist. But what we try to do in our interventions is to build within them important strategies and to help them work on expectations for what they will be getting out of our intervention. So we spend a lot of time tailoring the exercise and weight loss intervention to the participant. One size certainly doesn't fit all. So we talk a lot about barriers, common barriers such as time management, pain in this population, and fatigue. We talk about what to expect and over what timeline in terms of what exercise and weight loss may do for them over time. And we spend a lot of time focusing on self-efficacy. So let's talk a little bit more about self-efficacy. Self-efficacy is someone's belief in their capabilities to produce desired effects by their own actions. I like to think of it as just a situation-specific form of self-confidence. So thinking of that little engine that could, it's what I believe I can do with my skills, not necessarily what abilities I have, but the idea that I think I can, and I think I can. How we measure self-efficacy, this is just one example specific to exercise. We talk about questions, do you believe that you can walk for 2 blocks in 4 minutes, or 8 minutes, or 10 minutes? And they score that belief along a scale from not at all confident to highly confident. And that scale might range typically from 0 to 100%. Why do we focus so much on self-efficacy? Well, we know that self-efficacy influences behavior. It impacts the behaviors we choose to engage in, how hard we're going to persevere in the face of barriers that we spend a lot of time talking about. And we know that it impacts affect and emotion. So because it has these very important outcomes, we try to influence self-efficacy. According to Bandura and thinking about social cognitive theory, there are 4 primary sources of where we base our self-efficacy judgments, how we determine just how confident we are. Mastery experiences are perhaps the most important source of self-efficacy. How we do over time is very important. And so we design our interventions to be incremental so that we can gain success and mastery in small steps over time. We also look at others who are similar to ourselves, so vicarious experience plays a role. If I see another older obese adult engage in exercise, then maybe I believe that I can do it too. Verbal persuasion, we give a lot of encouragement to our participants, and we help them to interpret their physiological states. If they're feeling pain while they're exercising, how might you interpret that? How might you think about how you're feeling as well, physically as well as emotionally, while they're participating in interventions that involve physical activity in weight loss. So using that information and building on social cognitive theory as our framework, what I'm going to talk about today specifically is a randomized clinical trial that we conducted at Wake Forest University between July 2006 and April 2011. The main objective of the IDEA study was to determine whether a 10% reduction in body weight induced by diet, with or without exercise, would improve mechanistic and clinical outcomes more than exercise alone. And Steve Messier is the PI of that project, and you can find the main outcomes paper in a 2013 JAMA journal that was led by Dr. Messier. This study included sedentary, older, overweight, and obese adults who had symptomatic NEOA with the experience of pain on most days of the week. They were randomized into one of 3 interventions: exercise only, which was 60 minutes 3 times a week. I will show you the center in just a second. Diet only, weekly sessions, months 0 to 6. And we'll talk a little bit more detail about the diet intervention. And then a combination of the 2 was the third arm over this single center 18-month randomized clinical trial. Here is the center where the exercise was conducted. This is here on the campus of Wake Forest University. And in the inside, this is our participants walking around the track where they do a 5-minute warm-up, 15 minutes of walking, 20 minutes of weight training, followed by another 15 minutes of walking, and a short cool down period. You can see them here both walking and engaging in the resistance training. In the diet intervention for weight loss, the initial energy intake deficit was 800 to 1,000 kilocalories. This intervention included lean shakes provided by the study or a suitable alternative of the participant's choice. We talked to them about meal replacements, about snacks, and group and individual sessions occurred working with participants to self-monitor their diet and their weight. Again, with a weight loss goal of greater than or equal to 10% of their body weight over the 18 months. The behavioral side of this study, we know exercise and diet, they come into the study wanting to do that, but how to help them approach that, again, was based on social cognitive theory and on group dynamics, working with people about the participants on how to make these changes, helping them build realistic outcome expectations, setting realistic goals. We used what we call the behavioral toolbox, where we really incorporated social support among the participants and the interventionists, provided incentives, so they came in for a lot of testing. This was over 18 months. And I want to talk about how we targeted self-efficacy specifically. So again, back to those 4 sources of self-efficacy information, we really built this into our intervention. They were tailored to the participant's ability and gradually increased over time so the participant could experience mastery and success. We gave them progress reports that visually showed them that success over time. Vicarious experiences, they were assigned to a group where they attended in the diet group, diet counseling, in the exercise group, exercise sessions, but both had group sessions with them with other older, overweight, and obese individuals with knee osteoarthritis. We built in patterns of frequent contact, really showing interest in our participants. Our interventionists are the best and are really well trained and really know what they're doing to work with participants and give them encouragement when needed and helping them create realistic, measurable, obtainable goals. On the interpretation of physiology and emotion side, our team helped participants interpret their responses to starting an exercise program, understanding that there might be some soreness following the beginning when they first were starting. And we showed them how to monitor their heart rate, how to complete their activity logs, and how to also accept disappointment and knowing that forgiveness, especially in a diet intervention, is a really important piece, knowing that everybody can't perfectly, we're always going to have that holiday or that day where we don't follow our diet, and how do we move on from that? So those were all techniques that we built in from day one over the course of this 18-month intervention to specifically impact self-efficacy. And we measured efficacy in 3 ways. A scale that looked at walking duration. So do you believe that you can walk for incremental durations of time? A gait efficacy scale, again about walking, but how confident are you in your ability to walk in the face of different obstacles and barriers? And then a third one, not specific to mobility, but now tied to balance, to navigate daily activities while maintaining your balance, and how confident were people to do that. So these are all 3 validated scales that we used to get at self-efficacy. So who were these participants? Well, there were 454 of them, and 88%, pretty proud of that, completed the study. We worked really hard to keep them in the study over the 18 months. There were no significant differences between the 3 randomized groups at baseline. And in general, our participants were older adults, primarily female, white, obese. And when compared to community-dwelling older adults, our participants reported less physical activity. Of course, they were sedentary at baseline, much like most of our community, but similar. And they did walk shorter distances on the 6-minute walk at baseline. Now, just to focus in on self-efficacy down at the bottom there, they showed moderate levels of self-efficacy along those 3 scales. So they're moderately confident in their physical abilities. At baseline, looking at Pearson correlations, participants who had higher self-efficacy or higher confidence reported significantly better function, less pain. They walked farther on the 6-minute walk test at baseline. And they self-reported greater amounts, albeit not a lot of physical activity, but they had greater amounts than their counterparts who had lower self-efficacy. The intervention itself, again, back to its primary outcome. So just to show you that we did achieve the weight loss goal. And the diet and exercise intervention had more weight loss over the 18 months than the diet alone. And both of those groups had, as you can see, more weight loss than the exercise alone group down at the bottom. But back to what we're focusing on today. What about the intervention effects on self-efficacy? Just how confident were these participants in their ability to engage in physical function and physical activity? These are 3 graphs looking at the 3 different measures of self-efficacy. Blue is D only, yellow E is D and E, and the red or maroon bar is E only. And you can see the differences being in the group between the groups in self-efficacy at 6 and 18 months. For walking duration efficacy, the E only group was significantly greater than the diet only, but the D and E group was significantly greater than both at 6 and 18 months. Also, for that Gait or mobility efficacy scale, D and E was greater than E only and D only at 6 and 18 months. And for the balance up in the top left-hand corner, again, D and E won the day and was significantly greater than E only and D only. So all combined, looking at all 3 measures of self-efficacy, the impact of weight loss and exercise together, the D and E group, on mobility-related self-efficacy, all three measures of self-efficacy related to mobility and balance, shows us that that impact deserves greater attention in the treatment of osteoarthritis. And it's something that we really want to pay close attention to. We did go one step further. So again, you might say, well, what does it matter? Who cares that it had this impact on self-efficacy? So we did a mediational analysis, and we were able to show that self-efficacy, and I'm just showing one here for the sake of time, but duration self-efficacy was the most potent mediator, and it significantly mediated the effects of the diet and exercise group on the primary clinical outcomes, including the 6-minute walk time, not time, it's the 6-minute walk distance, that should say, gait speed, WOMAC function, and self-reported pain on the WOMAC as well. So it has important outcomes. So how we influence it matters, because self-efficacy plays a big role in important clinical outcomes, and it also plays a role in adherence. Limitations, always have to talk a little bit about the limitations that we had in looking at these particular analyses in the IDEA study. We didn't measure self-efficacy at other time points. We have it at baseline, 6 months, and 18 months. So the trajectory of self-efficacy throughout the intervention is really unknown. Other studies on self-efficacy have shown that the greatest declines are seen in the months just prior to the completion of the intervention. So they may have actually had higher self-efficacy prior to the knowing, okay, this is about to end, it's almost 18 months, and we actually see a decline perhaps by the time we get them in for measurement and testing at 18 months. We also didn't measure self-efficacy specific to weight loss, and there are skills out there now that we would use in the future that have been shown to be a predictor of successful weight loss and successful maintenance of that weight loss over time. So that would be a participant's belief, their confidence in their ability to engage in dietary behaviors that are very important to weight loss, not just the exercise and physical behaviors that we measured with our efficacy scales. And again, the delivery of the intervention, it was tapered in terms of individual contact at 6 months. That could have possibly led to some of the declines we saw from 6 to 18 months in self-efficacy. But without measurement of self-efficacy at other time points between that 6 and 18 months, it's really unclear what that effect of that tapering might have had. And the participants in the E group, both of the E groups, most of them continued to come into the center. They had that option if they wanted to. Implications of this work. Well, I think these findings add to the earlier work, the primary outcomes by Dr. Messier, strengthening the idea that the combined intervention of exercise and intensive weight loss that's built on social cognitive theory increases not just physical function and decreasing pain, but it also has an impact on self-efficacy. In turn, that increase in self-efficacy has an impact on clinical outcomes and physical activity adherence over time. And we would hypothesize, so we don't have the weight efficacy measure, that if we did, that would also play an important role in weight loss maintenance over time. Our study that was based on social cognitive theory and self-efficacy really enhances the beliefs held we can do this. We can make a difference. We can impact their beliefs and their abilities to maintain balance, to walk while navigating obstacles, and to walk at increasingly challenging different distances over time. I think that to me is the really interesting piece that we're going to look at even more, is the idea that self-efficacy acts as a mediator in these relationships. And that's the two-sided coin that I talk a lot about with our team, that self-efficacy has a two-sided coin. So diet and exercise impact self-efficacy, and then in turn, the other side of that coin is that self-efficacy has an impact on adherence and clinical outcomes. And that's what makes it so important and crucial to our interventions. And with that, I'm going to close up right about at my 20 minutes and see if anybody has any questions.
Thank you, Shannon, for your presenting today. Just a reminder, you can type any questions you have into the chat box in the bottom right. So while we're waiting on the questions to come in, Shannon, I actually enjoyed your presentation. I do have one question to ask. So what do you think the biggest challenge to have the older adults stay active throughout that whole 18-month process?
Well, 18 months is a long time. That's why you don't see many of these studies, going that long. But we thought it was very important to have an impact on, clinical outcomes and to have that weight loss over that long period of time. To help people with their adherence, we spend a lot of time as a team talking about going to that behavioral toolbox that I mentioned earlier and really emphasizing all of this built on social cognitive theory and group dynamics, really working on building social support, on helping our participants see over time that incremental successes. That's why we give them feedback verbally, but we also print out and give them, actual how many minutes they've been walking and how they're doing, how their weight has changed over time, helping them tie that to realistic expectations and setting goals, working with them really closely to tailor this intervention for the participant. And I think that's the key to these trials is tailoring, working with individuals so that they can learn over time. We're with them. We're really right there in the center, but over time they're going to need to do this on their own. And that's the ultimate goal, is maintaining this weight loss over time so we can see its impact down the road. And I think one important piece of doing that is going to be increasing their confidence in their ability to participate in physical activity in the face of barriers in the real world, and to participate and keep going with their dietary strategies, whether that's using logbooks on their own, setting their own calorie budgets, setting their own goals for when they go to that big holiday party. All of those pieces is working with the participant to build within them the skills that they need to go out there and do this in the real world.
Thank you, Shannon. That information is very beneficial, and I think participant host management is definitely great. So we have a couple questions in the chat box. One question is: has the double-sided coin theory been demonstrated in other contexts?
Yeah, Albert Bandura is the father of social cognitive theory, and even in his early works writing about self-efficacy, he talks a lot about self-efficacy in three different ways. One is an outcome. So in a lot of trials, especially in the exercise literature, showing that we can impact individuals' beliefs and their abilities with exercise. But also looking at self-efficacy as a predictor, so the independent variable, looking at self-efficacy having an impact on adherence. And there's been a lot of work done, not just in exercise, but diabetes is another interesting chronic disease to look at, and efficacy has been shown to impact the self-care behaviors needed in that chronic disease population. And then if you take all that one step further, that's the two-sided coin piece that I just put it that way. I think it helps visually to understand the role efficacy plays as a mediator. And if we intervene on self-efficacy with our interventions, it will in turn lead to positive clinical outcomes and enhanced adherence. And I think that that's been shown in bits and pieces in many different behaviors, certainly with exercise, some with diet, and in various chronic disease populations.
Okay, well, thank you for answering that question. We have another question in the chat box. Did you assess how much people were doing physical activity outside of the group sessions?
Yes, we did. We used the PACE scale, which is the physical activity scale for the elderly by Washburn and colleagues. And so they did that self-reported physical activity tool at baseline, at 6 months, and at 18 months. Even those people who were in the D only condition, who didn't come to the exercise group sessions, they only came to diet. So we could look at changes in physical activity that would have included what they came into the group and anything they did on their own outside of the group. Now, after 6 months in the exercise groups, those two arms that had the exercise piece, they were given the option that they could continue to come to our center, or they could go out into a facility of their own choosing. Most love our center. It's a beautiful place and many continue to come there, but we also helped people transition. Some of them lived maybe 30, 40 minutes away, and they wanted to transition perhaps to a YMCA in their community. And so some of them did that. We worked with them on developing logbooks. They would check in with us periodically, and we would gather that information from them. But again, for everybody, still, we did look at that physical activity trajectory using the PACE scale.
Great information. Thank you, Shannon. So I don't see any more questions in the chat box. Let me see. 1 second. I think someone's typing a question. Okay, so we have someone that just wants to share. She says, I like the fact, she likes that the positive intervention technique, it's okay to make a mistake. This really helps individuals get back on track.
Yeah, if I could just comment on that. We really, being in a clinical trial environment versus in a community environment per se, once we have a participant, they're ours to keep. And, we want to keep them in our trial for lots of reasons. We also want them to be successful as well as, having a good adherence rate for our study. And we would have people come to us that would say things like, I've had a really hard month, life happens, amazing stories that these people have over the course of 18 months, the things that happen in people's lives. And they would say, I'm doing more harm to your study than good, so I should just drop out. And we talk about that. No, absolutely not. This is how life works. And some months, some days, some meals, whatever it might be, we just might not be able to participate, and that's okay. And we actually talk about forgiveness and of ourselves. And it's okay that you had a loss in your family and you really went off your calorie budget this month. That's okay. And we're here to work with you when you're ready to get back on track with your calorie budget. Is just one example. And I really think that positive interaction that we have helps them to build their own strategies that I hope they'll be able to then really pull from once they're no longer in our intervention with us, and be allowed to realize that one bad day, one bad month is not a reason to throw up their hands and just embrace obesity forever. That's certainly not what we want. So we have found that the participants have really embraced that, and I think not just from our team but also among each other. You really see them encouraging one another in the group sessions, and that's really helpful too.
Great. Well, thank you so much, Shannon. We have a couple of the people who questions you answered were saying thank you for that information. And will the participants be able to have access to the slides or your presentation, or how would they be able to have access to them?
I thought, do you just post them, right? Is that what you do?
Yes. Okay. So yes, we will post our video on our YouTube channel, and then that's how everybody can have access to them.
Great. And of course, I'm here, at Wake Forest. I guess before you post them, maybe we can put my email on there. And if anybody has any follow-up questions, I'd love to hear from you.
Well, great. Well, thank you so much, Shannon, for presenting today, and thank you all for joining us. We will be releasing details on next month's webinar very soon, so stay on the lookout for that. And thank you again, Shannon. We enjoyed your presentation.
Thank you.
Bye.